So now with this introduction of the nomogram, the 5-point nomogram, we'll just see it in action with a few case examples. So the first case would be a 35-year-old female who comes for a routine checkup and was detected with keratoconus incidentally. She had no history of eye rubbing or allergies, no frequent change of glasses. So if you go to the demographic risk factors, you see according to the age, no eye rubbing, no atopic eye disease, no frequent change of glasses. The risk score for this patient is 0. So coming back to the 5-point nomogram, how would you treat this patient? You would either give this patient glasses or contact lenses based on the contact lens tolerance. The second case is a 27-year-old male, history of active atopic eye disease, past history of eye rubbing, he is contact lens intolerant and also complains of frequent change of refraction. Going back to the risk factor, giving the age of the patient 27 years would give him a score of 1, atopic eye disease score of 2, past history of eye rubbing again score of 1 and frequent change of refraction score of 2, giving him a total risk score of 6. So this patient would be classified as a moderate risk candidate. Again, based on the 5-point nomogram, we decided to go for an intax combined with a cross-linking procedure. So we decided to go with an intax. Now the decision-making nomogram on what intax, whether to use symmetrical, asymmetrical ring, regular or steep K rings is based on this nomogram which we have designed at Narayan Netralaya and it's also published in IJO. So this particular case had a central cone. So we decided to go with a symmetrical ring. He had a mean K of more than 55 diopters and therefore based on his spherical equivalent of 3.75 we decided to go with a symmetrical SK rings of 0.4. I'll be playing this video later on and this is his post-op topography and the difference map shows a difference of almost 4 diopters. Coming to the third case, a 19-year-old female with active atopic eye disease and active eye rubbing. She complains of frequent change of glasses. She is a known case of keratoconus since 4 years. And based on her risk of all these factors, her total risk score was 8. And she therefore comes in the high risk group. Based on the 5-point nomogram, we decided to go aggressive and go with the topo-guided PRK combined with the cross-linking procedure. So this is her preoperative topography based on which an ablation profile is designed and this is her topography post-operatively after the TPRK, after which a cross-linking procedure was also done. Now the fourth case, a 22-year-old female, she was just got pregnant. She had come with active eye rubbing and past history of atopic eye disease, also a known case of keratoconus. Based on the risk factor, she had a total risk of 6 and she was in the moderate group. Based on the 5-point nomogram, we decided to go with the cross-linking and epi of cross-linking because she had a good pachymetry. So as Sir has already mentioned, the type of cross-linking depends mainly on the pachymetry. You would go for an epi of with a pachymetry of more than 400 microns. And if the pachymetry is less than that, we can either go with a hypoosmolar epi of cross-linking or a transepithelial. The last case was a 32-year-old male with advanced keratoconus and also had central corneal scarring. The refraction was not recordable. In this particular case, we go directly because it is an advanced disease with scarring. There was no other option but to go with a PK in this patient, and this is the image post-operatively. Thank you.